A lot of complicated things to talk about, so we'll get started. The patient of the week in the New England Journal is a 65-year-old man who is otherwise healthy. Lesion on his hand and a lower forearm. He lives in China. He works as a farmer and developed this lesion in the course of agricultural work. So what we see here is a petri dish with cultures. Looks like a fungus, and indeed, if we look, this is a fungal infection of the hand, and it's unlikely to be cutaneous leishmaniasis, which doesn't look like this. Scrofula is tuberculosis, skin tuberculosis. We've talked about that recently. Sarcoidosis is not caused by a fungus. Tinea versicolor is caused by a fungus, but certainly doesn't look like that. So if the infection is based on working with soil material and it's fairly indolent and has these annular kinds of lesions, this has to be sporotrichosis. And indeed, that's the correct answer. And this infection was treated with various antifungals, and it takes a long time to get better, but eventually this patient recovered. If we look at leishmaniasis, leishmaniasis is spread by sandfly bites, and a lot of patients in the Middle East suffer from cutaneous leishmaniasis as opposed to visceral leishmaniasis, but this is a typical lesion from cutaneous leishmaniasis. Certainly looks different than the lesion we saw in our patient today. Here's another example of sporotrichosis. I'd like to draw attention to the fact that not just working with soil directly, as in gardening, for instance, but also contact with animals that have contact with soil, dogs and cats, etc., can result in sporotrichosis, hand infection with these various nodular lesions as shown here. This patient had contact with a cat. Cutaneous tuberculosis takes various forms. We've covered this topic here relatively recently. This is called scrofular dermatitis, and here's an example of several lesions that are caused by tuberculosis. Of course, in culture, they look substantially different than what our patient had today. Sarcoidosis is probably a T-cell disorder. It's not an infectious disease. Has various ramifications that are rather protean. I'd just like to draw your attention to the fact that we had a paper in the New England Journal in December where cutaneous sarcoidosis was treated with tofacitinib to inhibit JAK-STAT signaling pathway, and that looks like a promising treatment for cutaneous sarcoidosis and perhaps even systemic sarcoidosis. This patient has tinea versicolor, results in these strange pigmentary changes in the skin. Malassezia furfur is the fungus that's involved. It looks morphologically quite different than what our patient had today. The first paper in the New England Journal on February 20th has to do with electric cigarettes. They elaborate a vapor. So the use of electronic cigarettes in the United States is called vaping. That's a neologism for 2018 and thereafter. And how these things are constructed is shown here. It even has a USB port. I'm not quite sure what the point of that is, probably to charge these things. But at any rate, in this study, vaping was compared to nicotine replacement to try to keep people from smoking regular cigarettes. I'd like to point out that we have no evidence that vaping is less harmful than regular cigarettes, although it certainly does cause less of a mess. So these patients, almost 1,000, were randomly distributed to various nicotine replacements or vaping, in the hope that that way they would lower their daily cigarette consumption. And that's shown here. So the nicotine replacement group got patches, gum, lozenges, nasal spray, various ways in which nicotine can be delivered to keep people off of cigarettes. And the vaping group got a starter pack, and you can inspect details by reviewing the file. Now, what we see here is that the patients preferred vaping to nicotine replacement by a whopping 100% difference. 79% of the vapors were still at it, compared to only 44% of the nicotine replacement subjects. The daily use for the entire 4 weeks showed results that the e-cigarette group, the vaping group, did far better than the nicotine replacement group. And if we look at urges to smoke and abstinence at 1 week or 4 weeks, this is a short-term study. I'm not quite sure why the New England Journal accepted this paper. I guess we would expect this result. So it looks like vaping provided greater satisfaction and was more helpful to refrain from smoking regular cigarettes than other nicotine replacement methods. So in conclusion, e-cigarettes were more effective for smoking cessation than nicotine replacement therapy, although the patients still preferred regular cigarettes even to vaping. There was an editorial on this. The FDA is trying to ban flavored products. They've tried to ban menthol cigarettes in the United States, but as far as I know, that strategy has been a failure. They haven't managed to do that yet, and they're trying to avoid companies that provide these e-cigarettes from flavoring the materials, because they believe there's common belief that teenagers like these flavors better and then would get hooked on vaping. The first topic in the New England Journal, or the next topic in the New England Journal, involves epidermal growth factor receptor signaling, in particular HER2, which is expressed on almost a third of all breast cancers, and it's expressed in various strengths, from HER2 negative to HER2 markedly positive expressing tumors. We have therapies that can be directed against HER2, and you're aware of the antibody that's used for that purpose, called trastuzumab. And trastuzumab is indicated in patients with breast cancer that express this receptor on the surface, HER2, and that involves about a third of the patients. Now, there's an additional strategy. We can couple the antibody against HER2 we can couple it with a drug conjugate, and the drug conjugate that's used here is mertansine, and mertansine is a tubulin inhibitor. This would then provide the therapy with a second hit, directing not only HER2 signaling, but also simultaneously also inhibiting tubulin formation. Microtubules are required for cell proliferation, and this might be a successful strategy in inhibiting the growth of breast cancers. That indeed was attempted in this trial, where patients with HER2 positive breast cancer, these patients had, as you can see from the table, had already been subjected to other therapies, dependent upon what else they expressed. But these patients with HER2 positive breast cancer who were found to have residual invasive disease were randomized to trastuzumab alone or a combination therapy abbreviated DM1 in this study, which involves the antibody coupled to this tubulin inhibitor. So here we see the randomization, fairly large numbers of patients to trastuzumab alone or trastuzumab plus this antibody drug conjugate therapy. And what we see here is the antibody drug conjugate therapy beats trastuzumab alone. If we look at the absolute difference here, it's not massive, but this is for invasive disease-free survival. If we look at overall complete survival, the difference is not significant, although there does appear to be a trend here. This middle panel is freedom from distant recurrence. So I guess I'd rather be in the blue group than the red group. And if we look at this forest plot, this combined treatment seemed to be better for the entire gamut of patients, irrespective of age or expression of hormone receptors or how far the disease had been progressed, etc. Now, there are adverse events to this treatment that were increased, including decreased platelet count and the development of hypertension for reasons that don't immediately occur to me. But hypertension wasn't that big a problem, but it occurred more commonly in the combined therapy group as opposed to trastuzumab alone. There were elevations of liver enzymes, but for the most part, the authors feel that the patients were able to tolerate this treatment fairly successfully. Now, we've talked about the difference in number needed to treat as opposed to relative improvements. The authors make the claim that with the combined therapy, there's a 50% lower risk of recurrence of invasive disease, and that's also shown in this table here. But if we calculate the number needed to treat, it's a little more modest than what these authors claim. But I guess I'd rather be in the combined conjugate group than in the trastuzumab alone group. The next paper in the New England Journal involves methicillin-resistant staphylococci, and this continues to be a major problem. And with the aggressive screening of patients, we're finding more and more patients that are MRSA positive in terms of having these organisms on their skin. And most of these patients have been in the hospital before because these problems are acquired generally in hospitals. And the idea here is what do we do with patients that are MRSA positive? Should they just be treated with education in terms of hygiene, etc., soap, etc., or should they at the same time undergo decolonization treatments with chlorhexidine mouthwash and showers and mupirocin ointments, nasal ointment, etc.? Would this really decrease hospitalizations? Would it decrease active MRSA infections, etc.? Would a very aggressive prophylaxis against MRSA be better than education alone? This hypothesis was tested in a large multi-center randomized controlled trial of these patients, and they were randomized to either education alone or education plus a fairly aggressive decolonization regimen, which requires a lot of effort and which was certainly not inexpensive. So here are the patients. There are about 1,000 in each group. And the primary endpoint was the development of MRSA infection. And there are various definitions of that, which is also a problem. And secondary endpoint was avoidance of hospitalization. So there were nurses assigned to administer these interventions. This is fairly complicated, particularly when we look at these different MRSA infection definitions in terms of CDC or clinical criteria or what have you. And then there's the problem between assignment, that would be intention to treat, or patients that actually prescribe to the protocol. And I think to give the authors a break, we should look at the comparisons of between the education group and the patients that actually underwent the intervention. So if we look at the patients that actually underwent the intervention, it looks a little better than the intention to treat analysis, and we'll give the authors a break here. And if we look at reduction of the relative risk, we can see a substantial reduction of the relative risk, irrespective of definition of MRSA infection in the intervention group compared to the education alone group. Although if we look at freedom from MRSA infection in terms of number needed to treat, and we'll calculate these numbers in a moment, the difference looks pretty darn modest for the amount of effort that was done here to do this study. So the number needed to treat to prevent an MRSA infection is 30. To give you a frame of reference, that's about the number needed to treat to avoid a myocardial infarction if you prescribe a statin. And the number needed to treat to prevent an associated hospitalization is about the same, it's 28. So this is an amazing effort, and this effort is not inexpensive, and the results are encouraging. They are statistically significant. I believe they're clinically relevant, although this is a heroic effort for this degree of improvement. The next topic is prostate cancer, and there are various strategies here. We discuss this topic here fairly frequently, and darolutamide is a treatment that not only blocks the testosterone receptor, but also results in its downregulation. So this is in essence a treatment for patients that are, in quotation marks, castration-resistant. We don't castrate the poor patients anymore, thank God, but patients that are resistant to testosterone receptor blockade or aromatase inhibition alone. So this is a more effective treatment that also involves downregulation of this entire signaling pathway. So this treatment was applied in patients with non-metastatic but castration-resistant prostate cancer. So what we see here is there are 954 patients in the darolutamide group compared to 554 patients in the placebo group with the so-called castration-resistant breast cancer. And these patients were observed for about 40 months. And what we see here is that metastasis-free survival certainly seems to favor darolutamide treatment. And if we look at this forest plot, all sorts of various subgroups also seem to profit to a similar degree. And secondary endpoints are shown here. Overall survival was statistically significant. Time to cytotoxic chemotherapies. There are other therapies that are applied for metastatic prostate cancer. Time to PSA progression, progression-free survival, all of these endpoints were better. And if we look at PSA progression, that certainly was impressively inhibited by darolutamide compared to placebo, and even median survival, although albeit fairly modest, was better in the darolutamide group compared to placebo. So darolutamide, as you can see from the structure, it's a non-steroidal androgen receptor antagonist that results in downregulation of the receptor. and it seems to offer these patients an additional advantage. The review in the New England Journal is aspiration pneumonia. This is a common problem. It can be required outside of the hospital or inside of the hospital. The approaches are different in these two groups. We're talking mostly about elderly patients that have difficulty swallowing for one reason or another. These patients also have chronic pulmonary disease or Parkinson's disease, neurological disturbances, or they've been on a ventilator, etc. Now, oropharyngeal dysphagia is common. It occurs in elderly patients irrespective of whether they have other problems or not, and where the aspiration pneumonia resides depends upon what sort of position the patient was in at the time of aspiration. And the upper lobes are commonly involved in patients who are lying on their backs, as opposed to lower lobe aspiration pneumonias. CT has provided a substantial improvement in diagnosing these patients. The condition is associated with enteral feeding, which most of these poor patients with neurological disturbances require, particularly if they're in intensive care units. And we can follow a schema here of hospital-acquired or community-acquired and what the CT or chest x-ray findings are, and a whole variety of other clinical criteria here can help us in making a decision on what sort of an antibiotic treatment these patients need. Their clinical features, what diagnostic procedures are open to us, bronchoscopy or lavage, etc. And the pathogens that are involved here has gradually shifted away from anaerobes and aerobes to include other organisms, which involves the decision of what sort of antibiotics should be applied. Chemical pneumonitis, patients that still make acid, that aspirate this material, all of these things are discussed in this review. And here's a whole host of various antibiotics can be considered here for these treatments, but probably more important is an attempt to prevent aspiration pneumonia if possible. And preventative regimens are shown here, and it would be important that you review these things if you were working in intensive care units. Here's a short clinical vignette in the New England Journal. It's a 64-year-old man who suddenly develops, not suddenly, but he presents with 2 weeks of shortness of breath, no chest pain. He's not undergone recent surgeries and has not had periods of immobilization. He has substantial hypoxemia. His oxygen saturation on room air is only 84%, so that's a PO2 of around 50. A CT is done, and we see these massive thrombi in both major pulmonary arteries. This patient had a remarkable echocardiogram, and if you can access New England Journal, you can watch this big right ventricular thrombus. So this patient was operated upon, and this material was cleaned out of his pulmonary vessels. And he then was subsequently treated with apixaban, which was probably a good idea. The patient in the New England Journal is a difficult one in my view. It's a 48-year-old woman that comes into an emergency room, apparently because she has no place to stay. And talking to her is difficult. She has a labile affect, rapid, tangential speech. It's not quite clear why she's there. It doesn't seem to be an acute problem. Blood work is done, and I think this laboratory evaluation is not easy. She is anemic, has a hemoglobin of 10. LDH is elevated at 325 units per liter. if we look at the size of her erythrocytes, they're, if anything, on the small side, although there is a substantial distribution in her erythrocyte width, which is the distribution is far greater than it should be. To my amazement, no peripheral smear was reported, so I presume that none was done. Because she had tingling in her fingers, there's an x-ray of her hands look normal. And because she seems rather peculiar, an MRI is done, and CT, and these evaluations are also not helpful. Various drug ingestions are considered here, but urine toxicology was negative. She has fairly grandiose thinking and believes that she's previously been a volunteer client at a psychiatric hospital in New York. Probably she was in one instead of being a therapist. So she claims that she was so brilliant that she skipped several grades in elementary school, and claims that she has degrees from Northwestern International University in Denmark, although that institution doesn't exist, and also a university in China. So a psychiatrist discusses the differential diagnosis here, and it's difficult because this patient suffers from delirium. Delirium is a false belief. Incidentally, that also occurs amongst politicians. No further comments there. But this is not a hallucination here, because the patient doesn't really hear voices, and she's not seeing things that are not there. Ich rufe zurück. So the psychiatrist discusses neurodegenerative conditions, inflammatory disorders, neurological disorders, and also nutritional deficiencies. And it turns out that this patient has a normocytic anemia, not a macrocytic anemia. And reports of serum iron concentrations aren't available, but it turns out that laboratory testing revealed a low plasma vitamin B12 level, and it's pretty low. She also has elevated homocysteine values, and methylmalonic acid level is substantially elevated, very much elevated. So this looks like vitamin B12 deficiency, which is certainly associated with a host of psychiatric disturbances. Although I would expect megaloblasts, I would expect a macrocytic anemia. And this patient didn't really have a macrocytic anemia. And indeed, as this case was discussed, another discussant suggested that this patient perhaps has a concomitant microcytic anemia from some other cause, but we have no peripheral smear. Now, she was tested for antibodies against intrinsic factor, which is more sensitive than antibodies against parietal cells as such, and she was positive for these antibodies. I would have probably put down an NG tube to see if she can produce acid, which I'm sure she probably couldn't. So this is an example of vitamin B12 deficiency. And I would ask you to remember that vitamin B12 deficiency is associated with elevations in methylmalonic acid, which we see in this patient, in addition to elevations in homocysteine, and that we can distinguish folic acid deficiency from vitamin B12 deficiency with methylmalonic acid. So this patient was treated for vitamin B12 deficiency and got better. So we'll move now to the Lancet, and what we see here This is February 20th. There are two important papers here. These are meta-analyses of how long does a hip replacement last, this is the first one. And those are important questions that patients ask. This operation is being performed for 30 years, and the patients want to know how long is this artificial hip going to last me. So this is the first review. Almost 3,000 papers were screened and various criteria were fished out here, so we don't have to worry about that. But what we see here is that 20 years after surgery, 70% of these hips are still working, and 25 years after surgery, it's almost 60%. And I thought those results aren't all that bad. And a lot of these results are based on a Finnish registry, and we can look at the various replacements that are done here, and I can't really tell what's better, but experts can pick out the hip replacement that seems to give the best result based on this table, although new devices are being produced all the time. So in context here, that we can tell the patients that they probably have a 60% chance that this hip will still be working in 25 years. The next paper is the same study in terms of knee replacement. And I would have bet that knee replacement does less well than hip replacement. Well, I'm wrong there. So here are 4,000 studies that were reviewed in this meta-analysis. And what we see here is that after 20 years, and knee replacement hasn't been around quite as long as hip replacement, the survival of the replacement looks pretty darn good at 70%, and at 25 years it's about 70%, so knee replacement does as well as hip replacement. So I think we can encourage our patients to undergo these operations, and that the long-term prognosis of these replacements is pretty reasonable. The next study is important because it's a randomized controlled trial in very young patients under 5 years of age, comparing general anesthesia to local anesthesia for operations that could be done with either procedure. And most of these operations in these young children were hernia repairs. And parents want to know if the doctors recommend a general anesthetic, that their child isn't going to suffer some consequences for a general anesthetic compared to local anesthesia. So these children were randomized, 722 of them, either to a generalized anesthesia strategy compared to a local anesthetic strategy. And there are details on this that you can review in these various tables shown here. Now, the anesthesia time was generally under an hour. Most of these patients were undergoing hernia repair. And what we can see here is that there was no evidence of any neurocognitive or behavioral difference with either of these anesthetic strategies. The next topic is glioblastoma. And the chemotherapy and radiation that's applied here is completely unsatisfactory, irrespective of which of these mutations might also be present in these resident tumors. The cytostatic agent is given here primarily as an alkylating agent, temozolomide, and it's generally accompanied by a radiation therapy. And there are mutations in a methylguanidine DNA methyltransferase that might provide some resistance against this alkylating therapy. So the patients in this study were randomized to either the first alkylator, temozolomide, or temozolomide plus a second alkylating agent, lomustine. And with the idea that perhaps this second alkylating strategy might provide an advantage for these patients. So here's the trial, here's the randomization schedule, here are the patients, and this is 63 or 66 in the two groups, one alkylator or two alkylators, and the radiation was applied here generally to both groups, and whether or not they got resections. And if we look at the dismal results with these two strategies, there's a modest suggestion that the two alkylators might be better than one alkylator, although the effects were so modest that the editors probably required the authors to say this new strategy might be better, could improve overall survival, although that outcome remains uncertain. The review in The Lancet on February 20th, week of February 20th, was epilepsy in adults, important topic. In my day and age, most of the patients that showed up with a grand mal seizure, and we have to separate those from focal seizures, or when the patients are not unconscious. By grand mal seizure, I mean generally aura, cry, fall, fit, tonus, clonus, urine, and fecal incontinence. Most of those patients either had problems with alcohol or they hadn't been taking their medications. Those were the two most common items in the differential diagnosis. A specialist should see these patients. This is certainly an indication for electroencephalography. The seizure types have to be considered here, treatment decisions have to be made, and these things were reviewed in a table here. Today there are imaging techniques that are extremely helpful, and patients that show up with a seizure episode should require imaging. Then there are new treatments. In my day and age, the patients got phenytoin or phenobarbital or both. But now there are a whole variety of other therapeutic options that can be given, although phenytoin still is on the list. And operations can now be done for patients with refractory epileptic episodes, and the outcomes are discussed in this review. And the strategies of when such treatments should be administered is also shown here in a tabular form. There are a variety of mutations that have been found in patients with particularly genetic forms of epilepsy. The role of immunological happenings, antibodies against NMDA receptors, and also antibodies against glutamic acid decarboxylase have now been found that can result in epileptic episodes. So this is an important review on an important topic, particularly if you're involved in emergency medicine or have occasion to see these patients. Then there's a review on acute encephalitis in adults that are immunocompetent, and that's a differential diagnosis compared to patients that are immunosuppressed. I think one thing that might be important for our part of Europe is a spring-summer encephalitis, which is a tick-borne form of encephalitis. In the United States, there are various mosquito-borne forms of encephalitis that have to be considered that are not that common in Europe. Here's a big tabular display of all these things. Meningitis also causes encephalitis, so various bacteria have to be considered here, tuberculosis, etc. So this is a good review on this topic, and laboratory testing that should be done here, and LP results, etc. are reviewed, and also the imaging strategies that are now available so that you can separate. Looks like toxoplasmosis here with these ring-formed lesions. This is all reviewed in this excellent review in The Lancet for encephalitis. Then, as we close, we're back to methylmalonic acid. You'll remember the patient that we saw in the New England Journal that had vitamin B12 deficiency, although she didn't have a macrocytic anemia. This is methylmalonic acid. Here's the methyl group, and here is the two acid groups for methylmalonic acid, just a reminder of where it comes from and the enzymes that are involved in that, and the metabolism of methylmalonic acid that involves the enzyme methylmalonyl-CoA mutase that is vitamin B12 dependent. And if we have vitamin B12 deficiencies, then we're liable to stack up on methylmalonic acid that then can end up in the urine. Now, the patient that's involved here is a 19-year-old woman. She's a little old for this diagnosis. She's admitted because of behaving strangely and uncharacteristically so for the last 6 months. She's unstable on her feet, so she has definite neurological symptoms and decline, and various imaging techniques are applied here, and nobody knows exactly what she has, so additional testing is done, and indeed she has methylmalonic aciduria. And homocysteine values are high, and her problem isn't a primary vitamin B12 deficiency, it's an enzyme mutation in an enzyme that's required to change methylmalonic acid to other products, and this condition usually shows up much earlier in childhood and is discussed here. She has late onset type cobalamin C disease, and there's a treatment for this, giving cobalamin, L-carnitine, beta-ine, folic acid, and vitamin B12 and other B vitamins is the strategy that's applied here, and the patient exhibited some improvement. And for your interest, I show you a schematic here of the metabolism of these various things involving not only this patient, but also the patient that we had in the New England Journal. That's the version in English. If you'd like to hear all this tedious stuff in German, stick around at 1700. I'll tell the same story in another language. Thank you for your attention.